right, I think everyone is in from the waiting room that's currently here. But since it's 12 o'clock, we'll go ahead and get started. I'm JC with the Peak program. Here with me, I have Cora, our graduate research assistant. Madison Parker is also on the call, and we are excited to have Dave present today as a guest speaker. Take it away, Dave.
All right. Thank you. Welcome to our Peak Lunch and Learn. We want to do a few things for you today. We want to talk a little bit about the background and history of Peak, kind of walk through all of that, and talk about what the incentive goals are with the add-on that's included in the reimbursement rate, and then talk about Peak today and where it is, and then finish up with some discussion about cost reporting and rate implications and how things flow through that are related to Peak in that regard. And then I guess finally talk a little bit about resources and finish up with just a question and answer period. So even though we've got that at the end, if you do have any questions that come up during the webinar, please just post those to the chat, and if I don't see it, JC will catch me and we'll go through those. And if you've got a question, I'm sure somebody else does too. So please bring it up. So to start with the background of Peak, so I've been privileged to be involved with Peak from the very beginning. And it was actually an idea that another administrator with the state of Kansas brought to us. It was based on a program that Michigan was doing called BEAM, which was bringing the Eden alternative to Michigan. So it's largely initially was based on the Eden alternative and had roots in that. To start with, it was just an award and recognition program that was trying to recognize those homes in Kansas that were doing good things with culture change. So at that time, the early 2000s, the idea was, can we move away from a medical institution, medical model to a more person-centered, home-like environment and that kind of thing. So again, it was focused mostly on culture change, that idea of moving to a social model. And at that time, there were no financial rewards or anything like that tied to it. So it was all recognition, and we did as much as we could, with press releases, governor's proclamations, and visits to the facilities that were recognized to try to promote that and just give as much positive press as we could to the good things that were happening. So we did that for about 10 years and weren't completely satisfied with the level of participation in that. So we kind of tried to reinvent things in 2013, and we called that Peak 2.0. And so that's kind of what we're living on today, although it's been modified more recently, and I'll talk more about that later. But the shift then kind of moved more of this from culture change to person-centered care. Can we focus more on that and to identify what it means to be a person-centered care home and try and quantify that or make that as an objective measurement as possible. And then we also realized that tying some reimbursement to it would be a good thing, that would actually probably drive more participation, we hoped. So that was the big thing, was tying Peak to an incentive program. And then another goal was to try to recognize differences in accomplishments. So we had some homes that were hitting everything that we could identify in terms of the alternative and person-centered care. But we had others that were just maybe starting, but they were doing good things in maybe a particular area. We wanted to differentiate between those. So that's what we turned to with Peak 2.0 in 2013. And when we set that up, there were actually 5 levels that things were broken down into, with the big target being the middle of that, person-centered care. So could we identify and objectively determine that a facility was what we would consider a person-centered care home? And at that time, we pulled together a group of stakeholders, administrators, and others from around the state, and had several meetings, probably for more than a year, to develop some criteria that we would use to evaluate that. What is a person-centered care home? And eventually that evolved to 12 core competencies, which we'll get into more. But that was the process then for evaluating that. And we tried really hard to come up with objective criteria that could be answered yes or no. Yes, they are. No, they're not. They're not quite there. And so again, that target was to get a home to hit all 12 of those core competencies and then be designated as a person-centered care home. But to encourage participation along that path, we wanted homes to at least start with just an evaluation of themselves. Where do they stand in that term? And when we say evaluate, what do the residents think of the home's level of person-centered care? What do the staff think? What do families think? And so we, at the time, developed or worked with, I can't remember which group, but developed a Kansas culture change instrument that would assess those different aspects of those 12 core competencies and perceptions amongst those different groups. And so if a home just agreed to do that and to begin looking at culture change, then that got them to level 1. So they could just simply commit to that process and enter into it that way. And then if they demonstrated that they had achieved some of those core competencies, that they were hitting some of them, then that would put them in this culture change achievement level. And then we also knew that we had certain facilities in the state that were well beyond just being a person-centered care home. They had sustained that for quite a period of time, and maybe were even opening their doors to others to come in and look around and help them, mentor them. And so that's what these upper 2 levels were. Can we show that they've sustained it, and have they become a mentor? So that's where we started initially in 2013. Over that time, that period from 2002 through present, even, I guess I would say those domains that we looked at initially, where we were recognizing performance, those evolved into what I noted were core competencies. So we focused first on resident choice. Do the residents have flexibility in maintaining really their activities, their daily routines when they go to the nursing facility, or they find a forced to give up things and fit to that schedule that the nursing home maintained. So that was the initial thing. And again, I think these were borrowed heavily from that Eden alternative effort. So resident choice, staff empowerment, were staff given the ability to make decisions and, affect residents' choices and things like that. And then was the home, had they done anything to try to move away from that medical institution feel to a home environment? And then finally, were there opportunities for residents to pursue meaningful life, whether they, ways to contribute in the facility, ways to communicate or connect with the community at large, and again, we saw over that 10-year period a lot of really good examples of all these things. But when we got to 2013, we tried to break that down more and then quantify it. And these have evolved much more since even 2013. But I've got these color coded. So resident choice, is broken down into food, bathing, sleep, and again, do the residents have some flexibility and ability to set those schedules for themselves? And then daily routines, can they maintain their daily habits and things, when they go to the nursing facility? Staff empowerment, are staff able to develop relationships, strong relationships? Do they have a decision making in terms of resident care and also in terms of staff work? Is there a career development pathway in terms of home environment? What about resident bedrooms, and what about the resident use spaces, those common areas? Are they designed to be more home-like, more than the institutional model that they had been previously? And then finding meaningful life, again, are they supporting the human spirit? And then is there community involvement? So again, those domains that we focused on initially, and I believe we actually awarded facilities in those specific areas, if they were excelling in any of those 4 areas, or if they were hitting on all four, they could earn more than one award, but didn't have it broken down quite to the level of the core competencies that we moved to in 2013. And then, like I said, those have evolved to present. So there's much more about those today than there was even in 2013. And again, that effort came out of a work group that was assembled, administrators and other stakeholders from around the state that came together and talked through, what do these things look like in terms of specific outcomes that you can say yes or no to in terms of what the facility is doing. So all of that change, was intended again to increase participation, really. It was one of the big objectives. And to kind of explain that, prior to 2013, with that awards recognition program, we had recognized, or the department had recognized, approximately 30 nursing facilities, 30 different facilities. Some had been recognized multiple times, but 30 different facilities over about a 10-year period, and had about 50 different facilities that had actually applied for recognition. So it was kind of a limited group. There's 300 nursing facilities, or approximate 300 nursing facilities in the state. So, roughly 10% had been recognized, roughly 1/6 had actually applied to be awarded something. So Peak 2.0 did change that landscape quite a bit. You can see in 2013, when it opened up, we had almost half, or around half, of the nursing facilities participate. So that was good. And then that grew from there for a few years. As things got more refined, and I think as things, were set, this is what is expected to be able to hit these different things. It got a little more challenging, and that declined. And then, of course, COVID hit, and that certainly had an impact. But the last few years, we've started to rebound a little bit. And I think hopefully that'll continue to grow, because ultimately the goal is to see as many homes achieve that person-centered care designation as possible. So that's a lot of background on it. So again, when we did create those financial incentives, the objectives of that were, I think really fourfold. One, trying to increase just the pursuit of culture change and person-centered care. We wanted to get more facilities to embrace that idea or pursue that idea. And we wanted to provide some incentive to try and offset the cost of doing person-centered care, because we know it's not a complete trade-off, or complete a zero-sum game. There's some expense that has to be incurred to do that. And so it was actually, again, set up where there's an initial incentive for just agreeing to participate and go through a process to evaluate yourself. So that's how that initially started. Again, we also wanted to recognize the differences in achievement, where you had some facilities that were clearly hitting on almost every aspect of what we considered culture change or identified as person-centered care. But we wanted to recognize those that were just beginning and differentiate that from those that had reached that higher level. And then also recognize those that were doing that work as a mentor or sustaining person-centered care. And then finally, we wanted to create a pathway, kind of a stair-step approach that, this is maybe where you start, and then can we just lead you up to that level of person-centered care and even beyond that to being a mentor. So then when you look at Peak today, so we do have this incentive program that adds to the reimbursement. It paid out roughly $1.5 million in incentives this last fiscal year. The Peak program, I showed you 5 different levels. That's where it started when we went to 2.0. But now I think there are a total of 9 different levels. I have a slide here later about that. But so there's several more steps, and it's really been streamlined or given, a way to escalate up that process, or those steps quicker. And each one of those steps has an escalating per diem. So there's a reward for continuing with it and sticking with it. In terms of resources, from the very beginning, the department partnered with the Center on Aging at K-State to develop resources to help educate providers about what person-centered care was, what culture change was, and how to go about implementing it. But those materials and things have evolved tremendously over the last 2 decades or, 15 years or so. And now you have really, really, I think, well-developed resources and easy to navigate content that's out there and available to you. So that was really important, helpful. We continue to do all that recognition that, started initially, through, visits from KDADs and other dignitaries to recognize the homes that are awarded that person-centered care designation. And then, recognition on the internet. Continue to do a governor's proclamation to try to call attention to those facilities and utilize as much as we can, social media and press releases to try to, again, just provide as much positive attention to those facilities as possible. And that's gained some attention, not just regionally or within the state, but also nationwide, where the PEAK program's been recognized by CMS, by the Pioneer Network, by Leading Age, and by the American Healthcare Association. So it's all been very good and continues to help promote that. So in terms of the current PEAK incentives, there are, like I said, 9 different levels. There's the foundation level, again, that's that beginning the process, just agreeing to do some assessment of the culture of the facility and go through and do some beginning steps to get the groundwork laid for that. And that equates to a 50-cent add-on, per diem add-on to the Medicaid rate. And then moving up, again, we've got these 12 core competencies that have continued and evolved. As you can show that you've achieved or are achieving each of those, the more of those you get, the higher your reimbursement can go. So it's not quite as tied to, a stair-step process. You could probably skip ahead if you manage to get to 5 to 6 and demonstrate that, you can fall back too if you start to fail on some of those. Ultimately, the goal again is to try to get as many homes as possible to hit on all 12 of those core competencies and get to that person-centered care home level. And then we've continued to maintain those upper 2 levels too, where we're recognizing homes that have sustained that person-centered care effort over multiple years. And then those other homes that have even gone beyond that and opened themselves up to being mentors to other facilities. Okay, well, I want to take a little bit of time and talk about program costs because, again, we acknowledge that doing PEAK and pursuing all of these changes, is not a zero-sum thing. It's not a total trade-off. That, again, was one of the reasons that the PEAK incentive was first put in place, was to try to provide an incentive for facilities to just start to pursue that idea of culture change and person-centered care. But ultimately, the cost that you incur to do the things that PEAK asked you to do, those things flow through to the cost report, and they actually go into the Medicaid rate calculation. Some examples, some simple examples of that are just staffing costs. Those go into the salary lines on the cost report, and those feed into the different components of the rate. So any staff time that's spent on PEAK or additional staff time that's added because of PEAK inspired policies, those things are going to go into that cost report and ultimately go into the rate calculation. The same thing's true for other expenses like food or supplies. As those costs increase because of PEAK, or if they increase because of PEAK, those things flow through to the cost reports as well and also get incorporated into the rate calculation. Another aspect is capital cost or capital outlays, things that you might do to modify the building or make it more home-like. Those costs aren't directly recognized like the other costs that I've mentioned, staffing and supplies and food, but those costs can be included to rebase the real and personal property fee, which is what is paid in lieu of ownership cost to the facility. So those also can be incorporated into the rate calculation. So to share a little more detail about that. So in the operating cost center, we're looking at administrative and plant operating expenses that the facility incurs. And so in that particular area, any salaries that are tied to administrative time that are spent on peak activities, those things would flow directly to that operating cost center and could increase that component of the rate. There's also a component of the rate called the indirect healthcare cost center. And again, that includes several salary costs, dietary, housekeeping, laundry, activities, social work, any of that time that's spent on peak activities or any increases in those staff times that are due to procedural changes driven by peak. Those things would also be captured in that cost center and could increase that part of the rate. Consulting is also a line item in the indirect healthcare cost center. So if there's consulting costs that are tied to peak or to policy changes driven by peak, those things could influence that part of the rate. Indirect care also includes food costs. So any increases there that are tied to peak would go into that cost center, as are resident activities and supplies, resident transportation, and then training costs. There's a line item in that cost center for training costs. So any training that's tied to peak that the facility has to incur costs for would go into that. The direct healthcare cost center, this is nursing and nursing supplies. So any salary costs tied to nurses or aides that's related to peak activities, or again to policy changes related to peak, that would flow into that part of the cost of the rate component. And then finally, that real and personal property fee, again, any capital outlays, so anything that's done to modify the facility in any way, those types of expenses, those can be used to rebase the real and personal property fee. And just to give you a brief overview, the real and personal property fee is set from the initial ownership cost of the building and carries through with the building, so it doesn't get deflated or rebased for new cost each year. But if a facility has expenses that are capital expenditures, they can submit that to rebase this, and that'll get added to that real and personal property fee. Some other considerations with rate implications. So anytime we do a quality incentive with the Medicaid program, CMS wants to make sure that there's a consistent message being sent. And for nursing homes, of course, there's the health survey process. And so that health survey process needs to align with what we do with the incentives, or the incentives, vice versa, need to align with the health survey process. So if there are findings from a health survey that are poor, then CMS expects the state to adjust those incentives to reflect that. So they don't want us to be, or the state to be, sending a mixed message where they recognize a facility for good things with an incentive, but on the other side of things, they're recognizing that there's some issues in terms of health survey performance. So to do that, Kansas uses a two-tiered approach, and based on those health survey deficiencies, if the scope and severity of any of those deficiencies is H or higher, then the home is not eligible for peak. And so there's a review period that's 12 months that we look back at. And during that time, if there's been a health survey that resulted in any of those H or higher level deficiencies, then the add-on is completely reduced to zero. So 100% of it's removed. The second tier is facilities that receive a G level deficiency, but no H level or higher deficiencies. Then as long as they've come back into compliance within 30 days, they're eligible to receive 50% of any qualifying add-ons. So if they've earned a peak add-on through the other process, then if they've had some issues with the health survey that resulted in that G level deficiency, then that add-on that they've earned gets reduced to 50% of what it initially would have been. So that's that two-tiered process that Kansas uses. And again, that was really driven by CMS's policy that we needed to make sure any incentives align with health survey findings. I mentioned the review period that we use on that. It's a 12-month look back, and it starts with the quarter one prior, 12-month period, one quarter prior to the incentive eligibility date. So I think the table here probably explains it best. So for rates that are set effective July 1, then we're looking at the 12-month period that ends March 31st. So July 1, 25, we looked at the 12-month period ending March 31st, 2025. And that rolls forward then each quarter. So for October 1, we'll look back at any survey completed between or through June 30th of 2025. For January, it'll go to September 30th, and April, it'll go to December 30th, 31st. So again, that's a rolling period. So even though the rates are set for July 1 and adjusted for January 1, there is this process that works on a quarterly basis to make adjustments to the incentive. Okay. I think there was a question also that came in about the timing of rate changes and how that works. So everything's really tied to July 1st. That's the rate setting reset. And so incentives are determined for July 1st. And if it's a level 0 add-on that the facility earns, then that's in place for one fiscal year. Although if the facility fails to continue to participate in some of the obligations that they have at that level 0, then they can be dropped out of that for non-participation. So again, it's put in place for July 1, and it's in place for one fiscal year unless they fail to meet some of their obligations on that. For levels 1 through 6, those add-ons again are granted for one fiscal year. And then for levels 7 and 8, those are actually renewed every 2 years. So a little different there. And then again, all those add-ons are always subject to that health survey adjustment. So even though they may be put in place July 1 at one level, if there's a survey issue that comes up during that year, then that could be reduced because of that. I talked about the reimbursement rates and how those costs flow through to the cost report, and then that flows through to the rate components. So that also gets reset every July 1st. And when we set those rates, we're looking at a 3-year base cost data period and using that to establish what those rates will be. That 3-year base period is generally reset every year. So every July 1st, that's usually rolled forward. For this fiscal year, that base period is 2022 to 2024. So any costs that were incurred in that period, 2022, 2023, or 2024, are going to be reflected in the rate calculation that we do. There's some exceptions to that. Providers that have gone through a change of ownership or new providers may not have cost data for that whole period. So there are rules that help us guide us through that. But in general, that's the case for most providers. It's cost data from 2022 through 2024. Inflation's applied to all of that cost data to move it to the midpoint of the rate period. So even though we've got 2022 costs and 2024 costs that might look different, when you apply inflation, that kind of puts them all to the same point. So it's a fair comparison. And then everything gets boiled down to a per diem in the end anyway. So we're looking at that. So again, if occupancies changed drastically between those years, that would also be reflected in the calculations. I said that, that base period gets reset annually. There are occasions when the budget becomes tight and the legislature intervenes and says, no, don't do a reset this year because it's maybe not affordable or can't be done. So that's one thing that process is subject to, is some legislative intervention. Again, if you start peak and you do something in 2024 or 2025, that cost is going to eventually work its way into the rate calculation. It may be somewhat diluted because you weren't doing that in the prior two periods or 2 fiscal years, 2 years that were used for the cost data, but it will eventually work its way into that rate calculation. Okay, so again, check real quick. No questions in the chat yet. If you do have questions, feel free to put them in there.
There's one.
Oh, is there?
So, yeah, how does the accountant who does the cost report obtain information regarding labor spent on peak?
So the accountant, I don't think would actually be too concerned about how to divide that labor between peak and other activities. What the accountant is going to do, the auditor that is going to do, is they're going to look at whether or not it's in the right cost center or not. Was that salary cost reported for the right staff in the right place? So that's what they're going to look at. So there's not something that I don't break peak out as a component in that base rate calculation. Again, those things flow through, and I'm going to skip back up to that slide, flow through to these different pieces. The operating cost center would reflect administrative time and salaries. Indirect healthcare would reflect those dietary, housekeeping, laundry. Direct healthcare would reflect nurses and aides. But there's no division to say that this is peak and this is not peak. It's just all flowing through to those different rate components. So if it increases that, again, that's going to flow through to the rate calculation. Now, there are limits to those things, but those limits are based on statewide calculations to determine what's the median in each of those areas. So the operating cost center itself has an overall limit that's based on that statewide median and a percentage added to that. And that's just really there to ensure that the rate that the state calculates, that we calculate, reflects some efficiency where we're not, saying we're just going to allow you to spend whatever. It's got to be, within some certain tolerance of what everyone else is doing. So that's the idea of that. But again, there's no breakout for these costs to divide peak from other cost or the other administrative cost or the other dietary housekeeping costs. Those are all just incorporated together. The incentive, again, it doesn't reflect cost at all. The incentive is actually separate completely. It's just earned by meeting some of those requirements that peak has set out. Hopefully that helped answer that question. If not, please post a follow-up and try to respond to that. Is there anything else yet in the chat, JC?
That's all I've gotten so far. And then someone asked about slides, which we can send those out after.
Yeah, certainly. Okay. So talked about the rate change timing. The last thing I wanted to share is the resources that are available to you. So you've got really a dual team for peak. You've got K-State, JC and her staff, and the others at the Center on Aging that help with peak. And then you've got KDAD's staff. And recently, Jamie Boone's taken on the role of the adult care home quality program manager. So you have a resource there that's focused entirely on that. So between KDAD's and K-State, there's a tremendous amount of information online at the websites that are listed here, but also resources available just by contacting them. So that's quite a bit of help that's available to you there. The other resource I wanted to point out is the Kansas Register, which is published through the Kansas Secretary of State's office and at this site that's listed there. Each year, the state goes through and reviews its rate methodology, and during that process, may decide to make some adjustments to the peak incentive as well as other rate components. And when they do that, they publish a public notice that explains what their plan is. They do it as a proposed notice in mid-April, and then as a final notice in mid-May. So they give a comment period, 30-day comment period to providers and stakeholders to review that notice of what's planned and then provide comment on it. And then the final notice takes into consideration those comments that have been received and other input. And that input can include, direction from the legislature as well. So again, it's not done in a vacuum by any means. But I wanted to point that out because that is available, and it actually also provides a historical reference. I actually went back, to try to look up how did we structure things initially in 2013, which because of the data retention policies where I work now, we don't maintain records back past 7 years, but the Kansas Register is available back, I don't know, maybe 40 years at least. And so I was able to look back at that and see exactly what that structure was from 2013. So again, those notices are generally published in mid to late April and then mid-May for the final. And sometimes it gets spilled over into June, but usually it's in May. So something to keep track of and monitor so that you know what the changes that are proposed are that are coming up, and also it gives you a way to look back at how things have evolved over time if you really want to dig into it. So yeah, so resources there, and then finally, just want to take some time and again answer any questions that you might have, or talk about concerns too. And I'll pause real quick and see if anyone has anything. And there's a couple of things here you can see to kind of prompt some thoughts if you don't think of anything immediately.
We had one more question in the chat about travel expenses related to peak. I'm guessing the ask is where should that go on the cost report?
Yeah. At the moment, I believe that the travel expenses would fall into that operating cost center. I'm not exactly sure of that. And I guess I would have to ask a little more maybe about what the travel expenses are. If it's resident travel or resident transportation, that's in that indirect healthcare cost center.
I'm guessing it would be like
It's-
for a mentor home experience, like when it's like
Yes,
program related directly.
Yeah.
precisely. That
it's-
is what the question was. It is about, we've had several homes asking Dave about travel for, we have one home traveling for something else peak related this week that I'm not going to say what it is. It's a surprise. And then mentor home experience travel or travel to the peak conference. And sometimes that does involve residents. Sometimes it's just them and staff, but that travel expenses, whether it's gas or extra time or hotel expenses or meals and incidentals, we were curious about if and how those could be written off on the cost report. And then I have one other thing after that.
Yeah, so the travel expenses for staff and mentor activities, those I think would go into the operating cost center. I will look at the cost report and make sure of that. I'm speaking off the top of my head. I don't look at it a lot anymore myself, but I'll go back and confirm that. Any travel expenses related to residents or resident activities would go into the indirect healthcare cost center.
The other question, and this is based off of a conversation I had with you, but I did not fully understand. It was you and Tricia, so of course I didn't understand. Was there like a 2-year period of writing off certain expenses for when you're tearing something up and rebuilding? Construction costs. There we go.
So the real and personal property fee, like I said, it's based on the original cost of the facility. And that calculation determines, okay, this is the fee that's going to be associated with the building and what the state is going to reimburse to the building, to the facility for ownership costs, so property costs. That can be rebased. So the easiest example I can think of is if the facility puts a new roof on the building, then they can accumulate those expenses and submit that, and We go through another calculation to determine what is the amortized cost of that per year for the life of that new expenditure. And then that can be added to that original calculation that we made to determine what that fee would be. The 2-year period is the window that they have to accumulate those things, because obviously construction doesn't happen instantly. It takes a process to do that, and it quite often can last beyond 12 months or 6 months. And so that's why facilities are given 2 years to accumulate those things. So, and that doesn't mean that you've got to have it all happen within 2 years either. You can accumulate expenses for 18 months and submit that for a rebase. You can start accumulating new expenses beginning at that endpoint or even before that endpoint and submit those later. It's just that when you submit them, you have to have them submitted within 2 years of when they were incurred.
Thank you,
That
Dave.
answer your question there?
It does. Well, I kind of understood it before, but it was something we wanted to make sure others fully understood.
Sure.
So the other questions that Sherry wanted to make sure were asked, you already answered because it was based off of travel, training expenses, and environmental changes. So you answered them all. Thank you, Dave.
Good. All right. Well, anything else, JC, in the chat at this
Not
point?
yet. I just sent a message to everyone asking if they had any concerns or questions based off the current slide.
Yeah. Thanks. Yeah, and again, we know that there's been some discussion about, well, I'm a rural provider and things are different for me than they are for an urban provider, or I'm a for-profit facility and that's different than a not-for-profit facility. So that's why we put this out here this way, is we wanted to try to get you to share some information or feedback on things that you see as challenges for you because of your situation. And we know every facility is going to have their own unique challenges because of their situation. But if there are things that you feel like are challenges, if you can share that, then that helps us try to address those, and maybe it helps others as well. So that's why we put that initial thing up there. And then beyond that too, this program continues to evolve. I think the most recent, revisions were done in 2023 and restructuring then, but every year it's open. So if you have ideas about, the add-ons or the tiers or the evaluation process, I think we'd like to hear your input there. And again, if you don't feel comfortable putting it in the chat now, send a message to one of those contacts, pieces that we've shared.
Someone had said our biggest concern is maintaining consistent staffing for an extended period of time.
Yeah. Well, that's always been a concern, right? I think that's the first thing I encountered when I started working with nursing home reimbursement 25 plus years ago, was staff turnover. How do you control turnover? And I don't know that, if there was a magic solution to that, then wow, that would solve a lot of problems for a lot of people, right? So I do think that pursuing person-centered care and culture change hopefully does address that to some extent, because hopefully you're going to help your staff build connections with residents that are going to help them see the value in what they're doing and feel, that purpose. And when they feel that purpose, hopefully that deters them from jumping to some other line of work but again, you always are going to be fighting those challenges of, well, working at that restaurant's going to pay as much as being a frontline staff person or something like that. There's always going to be that competition that you're going to have to face. And
Dave,
yeah.
And I don't know if you can personally say this or not. I just know from Stephen that somewhere in all the maths that I don't mess with, there is something that shows that peak homes actually do have a higher retention rate. And I thought that was through the cost reporting. Is that true? Is that through you? Can you see that?
Yeah, I don't have that, but I do think you're correct. I think Stephen Heim on your team at KDADS did put some information together recently, and I think we just looked at that not long ago. I didn't incorporate that here, but that is something that we can share. That what he looked at is, again, these are peak facilities or facilities that are participating in peak. And this is their average retention rate versus these are non-peak facilities and this is their average retention rate. So yes, hopefully, you can't say that this is the cause and effect, but you can at least say there's a correlation to that. And that's really one of the, things that you'll hear when you do go to those national seminars and other, if you participate in other events, that culture change and person-centered care does result in some outcomes that are beneficial in that regard in terms of, lowering turnover, increasing retention. And because of that, lowering some of the costs that you incur to train staff and things like that.
We got another comment on this. It would be advantageous if we were not penalized for PRN staff turnover, for example, college kids.
Yeah. Yeah, and that's, those kinds of comments, those are good because we can maybe find ways to incorporate something like that into the calculations that we do to determine staff retention. If there's staff that are going to be temporary like that or that are PRN, maybe we need to try to identify that and break that out of that general calculation or give you some allowance for that. Maybe you can have a certain percentage of staff. I'm thinking out loud in this. This is the kind of point that I think we can work with and try and figure out a way that we can adjust the schedules that we use, the data that we collect in order to maybe account for that. So I appreciate that comment, and I'll make some notes and try to follow up with that with Jamie and the others at KDADS that we work with to set those calculations. So thank you for that comment.
I don't have anything else.
Well, I don't have anything to add really, except that again, I point everyone back to those resources that are available because I think your website that you guys maintain for Peak at K-State is very impressive. There's a lot of good resources there and a lot of information. It's worth your time to go out and look at that. And the same thing with KDADS. There's a lot of good information there if you want to go and look through that. I mean, I would encourage you, if you're not participating in Peak, go out and check those things out.
Well, thank you, Dave, for taking time and presenting. Thank you, everyone who asked questions and shared some comments with us. I'll be on here for the next couple minutes if you have any program-related questions. But other than that, I think we're done for today. The recording will be posted on our website in the next couple of business days. And then I'll send out Dave's slides on his behalf. So yeah, reach out with any questions. Thank you, everyone.
Thank you, Dave.
Thanks, JC. Thanks, everyone. Bye.